Welcome, students! If you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. I am absolutely thrilled to welcome you to Part 127 of our IPDRG Masterclass. Now, last time in Part 126, we tackled ECMO cannulation, VA versus VV mechanics, and all those tricky duration rules. Today? Well, today we are undertaking a masterclass explainer on the true architecture of a claim. We're doing a pre-MDC deep dive into solid organ transplants. We're talking heart, lung, liver, and kidney DRGs. This right here is exactly where extreme clinical acuity meets incredibly complex reimbursement logic. So, let's get into it. Okay, let's take a quick look at our agenda. First, we'll cover solid organ transplants in the pre-MDC. Then we'll break down the high-volume DRG families, dive into ICD-10 PCS coding and complications, look at some real-world audit targets and case studies, and finally, wrap it all up with a summary and next steps. All right, starting with Section 1, Solid Organ Transplants in Pre-MDC, the absolute foundation. To really understand solid organ transplants, we first have to wrap our heads around this concept of global pre-MDC precedence. Normally, in standard grouping, the principal diagnosis determines the major diagnostic category, or MDC, right? But solid organ transplants, they bypass this entirely. The sheer clinical acuity and intense resource consumption of these procedures literally override all standard organ system MDCs. They automatically bump the case up to top-tier pre-MDC surgical DRGs. And alongside this, CMS requires strictly separated organ acquisition cost accounting. This means hospitals have to perfectly differentiate the standard inpatient MSDRG operating room reimbursement from the separate organ acquisition cost center billing. That includes all those massive costs associated with UNOS and OPTN matching, plus the donor procurement fees. It's a dual-track financial system. So the MSDRG grouper engine isolates these life-saving procedures into very specific high-volume DRG families. We're talking MSDRGs 001 and 002 for heart transplants. We've got 005 and 006 for liver and intestinal transplants, and 007 and 008 for lung transplants, whether that's a single, bilateral, or even an en-bloc heart-lung procedure. And whether a surgical team is doing an orthotopic liver transplantation, maybe a split liver transplant, or navigating the really intricate interactions of a simultaneous kidney-pancreas transplant, the grouper engine fundamentally respects the high-stakes environment here. It accounts for end-stage organ disease, organ availability, and those incredibly intense ischemic time constraints. Once a case gets routed into one of these pre-MDC surgical families, it then gets partitioned by severity. You know the drill. The MSDRG structure relies heavily on secondary diagnoses to determine if a case hits that highest tier, the one with a major complication and comorbidity, or MCC. In this high-acuity transplant landscape, capturing the precise clinical picture is everything. Things like hyperacute rejection monitoring or severe metabolic imbalances, documenting those is literally the only way to accurately reflect the true astronomical cost of caring for these critically ill patients. Moving right along to Section 2, let's explore these high-volume DRG families and the root operation transplantation. Over in the ICD-10 PCS system, Medical and Surgical Section 0 uses the root operation transplantation, and that's represented by the character Y. The precise, by-the-book definition here is putting in or on all or a portion of a living body part taken from another individual or animal to physically take the place and physiological function of all or a portion of a similar body part. Keep in mind, during this procedure, the patient's native body part might be removed or it might not be. This root operation is incredibly exclusive. It represents a very small number of highly complex procedures and only includes body parts that can actually, currently, be transplanted. Now, differentiating transplantation from the root operation transfer is absolutely critical for precise code assignment. You do not want to mix these up. Transplantation strictly involves putting in a donor body part, meaning it comes from another individual or animal. Transfer, on the flip side, involves moving all or a portion of a native body part to another location to take over a function without taking it out of the body. It stays connected to its original vascular and nervous supply. If you mix these two up, your top-tier pre-MDC grouping is going to fail instantly, no exceptions. Let's look at just how precise the ICD-10 PCS code structure really is. Let's say we're coding an open transplant of an allogeneic right kidney. We'd build the code 0TY000. It's like a puzzle. We start with Section 0 for medical and surgical. T is for the urinary system, Y is our root operation transplantation. The first 0 specifies the right kidney, the second 0 is the open approach. Z means no device, and here's the kicker. The 7th character qualifier in transplantation captures the genetic compatibility of the donor organ. In this case, 0 stands for allogeneic, meaning it's from a donor of the same species. You might also see syngeneic for an identical twin, or zooplastic for animal tissue. Now, as a quick side note, it's crucial to remember that synthetic heart assist systems, like LVADs or BVADs used for destination therapy or as a bridge to transplant, are technically coded under a different root operation, but they still drive cases into those exact same top-tier pre-MDC DRGs, 001 and 002.
All right, Section 3. Let's talk about ICD-10 PCS, clinical documentation improvement, and how we handle transplant complications. The reality is, the severity of a transplant patient's condition often stems from incredibly complex post-operative complications. This is where your CDI teams become the heroes. If a patient experiences primary graft dysfunction, severe ischemia-reperfusion injury, or develops opportunistic CMV or systemic fungal infections, the medical documentation has to explicitly state these exact diagnoses. Vague provider notes saying things like poor function or just infection completely fail to capture the life-threatening reality of the scenario. And worse, they result in severe underpayment for the immense hospital resources being consumed.
Whenever there's ambiguity in the chart, it requires formal, tracked concurrent queries. A classic absolute necessity in transplant coding is querying the precise nature of graft rejection. You have to ask, doctor, please clarify if the documented graft rejection is hyperacute, acute, or chronic. Capturing the exact diagnosis from the T86 series, which covers complications of transplanted organs and tissue from T86.0 to T86.4, isn't just good practice, it is a strict requirement for compliance and defending against audits down the line.
Let's bring this into focus with Section 4, real-world coding, case studies, and audit targets. Let's walk through a high-stakes clinical scenario. Picture this. A patient is admitted with end-stage liver disease for an orthotopic liver transplantation, or OLT. The surgery goes smoothly, which successfully places the case into the pre-MDC liver transplant family. But then, during an extended ICU stay, the patient develops profound hemodynamic instability and gets diagnosed with septic shock. Now, because septic shock is a major complication in comorbidities, this single, accurately documented diagnosis completely shifts the entire case to MSDRG 005, liver transplant with MCC. This is exactly how we accurately reflect the massive critical care intervention the hospital had to provide. Look, transplant claims are massive financial events. We're talking huge dollars, which makes them prime compliance audit targets. Proper bulletproof coding directly supports your payer denial defense. Your coding and CDI teams must meticulously validate the donor procurement documentation against the recipient inpatient claim rolls. You are constantly going to be required to defend the medical necessity of extended post-transplant ICU stays. And having robust documentation of specific complications, like the precise etiology of a graft rejection, well, that's your primary weapon to counter aggressive commercial payer downgrades. Okay, Section 5. Let's summarize what we've learned and look at our next steps.
To quickly recap our deep dive today. First, solid organ transplants override all standard MDCs to automatically assign top-tier surgical DRGs. Second, hospitals absolutely must separate inpatient MSDRG reimbursement from UNOS and Option organ acquisition cost centers. Third, when you're assigning that ICD-10 PCS root operation transplantation, remember that the 7th character has to specify genetic compatibility. And finally, capturing precise complications, especially using that T86 series for graft rejection, is absolutely critical for defending these complex claims against commercial downgrades.
So I'll leave you with this question. Is your clinical documentation actually robust enough to survive a rigorous payer audit on a $1 million transplant claim? When a single MCC can change the entire financial viability of a specialized surgical program, precision is everything. Think about that as you're reviewing your high acuity charts this week. Next time, in part 128, we are going to continue our pre-MDC deep dive by exploring allogenic and autologous stem cell transplants, as well as CAR T-cell therapy. If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. Keep decoding, and I'll see you in the next masterclass.